Welcome to all from Health Channel. Today I want to describe in briefly respiratory system embryology. The respiratory diverticulum appears on the ventral wall of the pubic foregut endoderm. Posted to the pharynx, the ventral wall rostral to the lung part now pinches off from the dorsal wall a parallel tube, which caudal elongation forms the trachea anteriorly and esophagus posteriorly. Respiratory diverticulum. The embryo approximately 4 weeks old, the respiratory diverticulum lung bud appears as outgrowth from the ventral wall of the foregut. The location of the bud along the gut tube determined by a signal from surrounding mesenchyme, including fibroblast growth factor that instruct the endoderm. Esophagotracheal ridge, foregut, esophagus, this respiratory diverticulum, and laryngeal orifice, laryngeal swelling. Development of the lower respiratory tract begins 22 days and continues to form the trachea, lung, bronchi, alveoli. The process divides into 5 stages: embryonic, pseudoglandular, canalicular, saccular, alveolar. The process begins early on fetal development. Complete maturation does not take place until the 8 years of age. Developmental delay is vital. Premature baby with their survival is intricately linked to which the developmental stage of respiratory tract has reached at the time of birth. Splunctopluric mesoderm derived from plural mesenchyme. Alveolar type 2 cell, alveolar type 1 cell. Alveolar type 2, their lamellar body, tubular myelin, alveolar fluid, the surfactant layer, alveolar. Surfactant protein A and B function in innate immunity, hence degradation of this protein may increase the susceptibility to lung inflammation and infection. Surfactant protein B and C contribute to surface property of surfactant. SPB and SPC organize the surfactant protein into tubular myelin, which is essential in reducing surface tension. Production of permanent surfactant begins early 24 weeks. Surfactant deficiency is the most common cause of neonatal respiratory distress syndrome, pulmonary surfactant production by a type 2 pneumocyte, and is responsible for maintaining lung surface tension. It spreads as a thin layer over air liquid barrier, thus preventing atelectasis end of expiration. 90% found phospholipid, phosphatidylcholine, phosphatidylglycerol, phosphatidylethanolamine, with them remaining 10% by protein. This primary for surfactant protein, surfactant protein essential. Mother risk of preterm delivery. Corticosteroids should be provided 23 to 34 week gestation, accelerate the lung maturation and surfactant production. At birth, the infant can receive an exogenous surfactant preparation, and surfactant preparation can be natural, such as those derived from animal lungs or human amniotic fluid, entirely synthetic. Currently, guidelines that preterm infant with the respiratory syndrome natural surfactant preparation should be administered. The surfactant. Risk of neonatal respiratory distress syndrome inversely proportional to the gestational age. Risk decreased from 60% at less than 24-week gestation to less than 5% of those infants born after 34 weeks. Infants typically present first few hours of life with tachypnea, hypoxia, hypercapnia, and breathing difficulty cyanosis. In the 24 weeks, alveolar saccule formation, surfactant detectable in amniotic fluid. Premature delivery, the stage of lung development, the saccular stage. The developmental arrest or delay and new bronchopulmonary dysplasia. The antenatal exposure, steroid chorioamnionitis, intrauterine growth restriction, and genetic susceptibility. And postnatal exposure, ventilator-induced lung injury, oxidative stress, infection, steroid, pulmonary fluid overload, nutritional deficit. Thank you for listening.